going to have two doctors now on the stage for you. So our first introduction is an award-winning consultant, oncoplastic breast surgeon specialising in breast cancer surgery. He is an honorary senior clinical lecturer at the University of Aberdeen and an e-tutor at the University of East Anglia. And that is Dr. Yazan Masannat. So if you want to get ready to come on stage, Doctor, that'd be great. And our second doctor who's joining him is Dr. Neill Patani. He's a consultant, oncoplastic and reconstructive breast surgeon at the UCLH with expertise in the management of breast cancer and all aspects of breast disease, including infection, benign conditions, and risk reduction. Please come to the stage. Or are we online? More surprises for me. And whilst I'm talking about the online, can we please all say a big hello to our global guests who've all dialed in watching this intently through the live stream. So say hello, everyone. Hello. Hello. Okay.
So who wants to go first?
Oh, okay, fine. It's up to you guys. The floor is yours. There's your
I'll hold you about it.
Yeah, is that okay? Let's move on to the next slide. Okay.
Good afternoon. Mary, thank you for the invitation to speak here. My name is Neill Patani. I'm one of the breast surgeons who works at the Princess Grace Hospital, London Breast Institute, and also at UCLH Hospital. I want to talk to you for about 20 minutes about the de-escalation of breast cancer surgery. So what does de-escalation mean? De-escalation is a concept which refers to avoiding overtreatment and reducing morbidity, enhancing quality of life and safeguarding the outcome of cancer patients. De-escalation of breast cancer can be summarised in 3 words, which are less is more. The communication of this concept to patients is very important though, because patients are obviously concerned about undertreatment. So I'll talk to you today about the history of breast cancer surgery. I'll talk to you about how our understanding changed, and then 3 time periods for the de-escalation of breast surgery, how we have already de-escalated breast surgery, how we are currently de-escalating breast surgery, and how the future may allow us to de-escalate breast surgery even further. So William Halsted was a pioneer of breast cancer surgery. The radical mastectomy was the standard operation for all patients with breast cancer for many years. The concept here was that breast cancer would spread from being a local disease to a systemic disease, and if your surgeon was brave enough and enough tissue was removed, you could be cured. But the outcomes from this approach were inconsistent and patients suffered significant morbidity. There was then a landmark change in the way we think about breast cancer when the idea of micrometastatic disease was popularized. Here we consider breast cancer as a systemic disease at the time of diagnosis in essentially all patients. And the theory was that systemic treatment, which targets micrometastases, would be the ultimate driver of patients' outcome. So just to highlight the difference, macrometastatic disease is present in a very small fraction of patients. Most of our patients have local regional disease, but the idea here is that all of these patients have micrometastatic disease. So we have already, as a group of breast surgeons, de-escalated treatment significantly when we have accepted that systemic treatment drives the outcome. By the control of micrometastases, radical surgery became a thing of the past. So there were landmark studies that showed that not all patients with breast cancer needed a mastectomy, and there was no value in removing normal breast tissue. There were landmark studies that showed that not all patients required an axillary lymph node clearance, and that for the majority of patients, mapping the sentinel lymph nodes would be acceptable. So removing normal lymph nodes would not improve outcome. Now these concepts have been extended further, and in current practice, about 20 years ago, we began to understand that breast cancer was not a single disease. It is effectively a collection of diseases which occur in the breast, and there are subtypes of breast cancer which have fundamentally different biology and natural history. So we cannot use this one-size-fits-all approach anymore. So clinical patients fall into 3 groups. You essentially have those that have hormone-driven disease, which is the vast majority, about 3/4. You have a smaller proportion who have HER2-driven disease, and then you have a sort of group triple-negative breast cancer, which is not really a group which is positively defined. It is just the absence of three things, so it's a very heterogeneous group and has historically been associated with poorer outcomes, but as I'll come to show you, this is now a group where we can achieve some of our best results. So the aim of de-escalation in modern practice is to combine and sequence different multimodal treatments, particularly systemic treatment and surgery, minimizing toxicity and optimizing the outcome for patients. About 20 to 40% of patients now don't have surgery as their first treatment. They receive drug therapy first, and when it's given before surgery, it's referred to as neoadjuvant systemic therapy, whereas treatments after surgery are referred to as adjuvant systemic treatment. So in the multidisciplinary meeting, there is often a friendly discussion between surgeons and oncologists about who should treat the patient first. So if you are going to de-escalate surgery, you need to carefully select patients. You can't do less for every patient. Some patients still need radical treatment and they still require surgery first. But if you pick the right patients with the right type of breast cancer and treat them with the right drugs at the right time, you can effectively turn the clock backwards. So cancers become smaller, lymph glands can become normal, and allow you to perform less radical surgery to the breast and less radical surgery to the lymph nodes. That creates another problem because cancers and lymph nodes become so small and so normal that you won't be able to find them during the operation. So there has been a rapid advance of technology to allow us to perform targeted and conservative surgery for this group of patients. So I'll take you through a few slides. These are not my own, these are patients from our breast institute, where this lady has a triple negative breast cancer treated with a combination approach of chemotherapy and immunotherapy, and the MRI showed a sequential improvement. This is a patient similarly monitored with ultrasound, so you can see that different modalities can be helpful. This is a patient with HER2 positive disease before treatment, after the chemotherapy component, which gave a good partial response, and then after the antibody treatment, which achieved a complete response. And the third case is again a HER2 positive patient, showing how systemic treatment downstages the breast and the axillary disease. We are achieving greater and greater success as we understand more about these cancers. With the advent of dual HER2 blockade using Herceptin and pertuzumab, these are both antibodies targeting the HER2, has allowed pathological complete response rates to increase for this group of patients. Adding carboplatin to the BRCA patients, and in particular, has also helped to achieve PCR results. And interestingly, for a significant proportion, the lymph nodes appear to respond more favorably than the primary breast cancer. So the type of breast cancer is a good indicator as to which patients will achieve a complete response. So in overall terms, about a third of patients who receive neoadjuvant treatment can achieve a complete response. The rates are highest for those who have HER2 positive disease and triple negative breast cancer. But the last line shows you that patients who have purely hormone sensitive disease can still achieve a very good response, although it's not in a majority of patients. Our group has looked at the response of DCIS. We've reviewed the literature in detail and shown that approximately 45% of DCIS associated with HER2 positive and triple negative breast cancer can also respond to neoadjuvant treatment. So the extent of microcalcifications at diagnosis should not commit you to a mastectomy. It is always worth breast conservative surgery, and if the DCIS has responded, you may be able to avoid a mastectomy. If we go on to the axilla, de-escalation has been important here in the same way that breast de-escalation allows you to avoid mastectomy. For those patients who require mastectomy, they at least have the option of a reconstruction. However, for those patients who require axillary clearance, there is no such thing as an axillary reconstruction. They suffer the morbidity of neurovascular injury and lymphedema. So de-escalation of the axilla has a special place in this talk. So we realized that women who have node-positive disease do not always require further treatment to the axilla. There was a landmark study called the Z11 study, which has been criticized for various reasons, but nonetheless has changed the mindset for women with relatively low-risk breast cancers and relatively low-burden axillary nodes, and frequently now these women have no specific treatment to the axilla and have equivalent outcomes in terms of their overall survival and excellent locoregional recurrence. For those women who have node-positive disease that require treatment to the axilla, surgery is no longer the only option. There was another study called the AMAROS study, which showed that for a selected group of women with cancers that are T1 and T2, with modest number of lymph nodes involved and no adverse features, you could give radiotherapy to the axilla instead of axillary lymph node clearance, and the control rates were comparable, and the morbidity of radiotherapy is about 50% in terms of the risk of lymphedema. Now, the Z11 and the AMAROS studies didn't specifically assess those women who have lymph nodes that are positive with extracapsular spread, and because of that, there's a lot of heated debate about what to do with those women, where the lymph nodes have escaped the capsule. And we currently manage our patients on a sort of case-by-case basis, but we're becoming increasingly more content with axillary radiotherapy for these sorts of patients. Again, our group has looked at avoiding axillary clearance after mastectomy because the Z11 patient population did not include mastectomy patients, and they were relatively underrepresented in the AMAROS study. But despite doing a pooled analysis of the literature, we're unable to show that there's any survival advantage for an axillary clearance in women who have a mastectomy with relatively low burden axillary disease. So even in these patients, it should be possible to offer axillary radiotherapy and rely upon systemic treatments, providing that they don't have adverse features. So the breast response rate is a very strong indicator of the axillary response rate. So you can see here that if you achieve a complete response in the breast, you can achieve a complete response rate in the axillary lymph nodes in about 24% of patients overall. And similarly, for patients who have a higher burden of axillary lymph node disease, you can also achieve a complete response. But that seems to be mainly for the triple negative and HER2 positive disease. The subtype is again important when you're deciding de-escalation of the breast maxillary treatments. So after you have given neoadjuvant systemic treatment to a node-positive patient, the question becomes how you sample the axilla. Historically, there has been an approach of performing axillary clearance on all node-positive patients regardless of their response, but because they achieve a very good response, sometimes that axillary clearance is unnecessary. So there was de-escalation towards doing a targeted approach towards the axilla, and this term targeted axillary dissection has come into the mainstream now, where diseased lymph nodes can be marked with either a clip or a reflector or a localizer, and then retrieved alongside the sentinel nodes during the axillary surgery after chemotherapy. So if you were to do a sentinel lymph node biopsy alone in patients who had node-positive disease, even if they have a complete imaging response, you can have a false negative rate of up to 13%. But if you retrieve the marked lymph node, which has been clipped or tagged, the false negative rate is reduced further, and if you're able to combine the marked lymph node excision with a sentinel lymph node biopsy using radioactive tracer and blue dye, you effectively have three mechanisms to identify these informative lymph nodes, and the false negative rate can be reduced to around 5%. So again, we've reviewed this literature in our group and found that the localization and retrieval rates for these lymph nodes is in the high 90% range, and interestingly, the sentinel lymph nodes are the marked lymph nodes in about 2/3 of patients, but for about 1/3 of patients, the sentinel lymph nodes are different to the marked lymph nodes that were clipped or localized before treatment started. And if you were to omit removing the marked lymph node or the sentinel lymph nodes, you would increase the false negative rate and understage the axilla significantly. So I think if you're going to de-escalate the patient and you want to prove they've achieved a response, you have to make sure that the axillary staging that you do is accurate and targeted. So otherwise you can underestimate any residual disease, and now that has massive implications in all the different subtypes because they all qualify for additional treatments if they still have residual disease. So this is just some pictures to show you how small these operations can become. These Saviscap reflectors are around around 7 millimeters in length, so you can see how small the breast cancer surgery becomes and how accurate the lymph node retrieval can be. So the idea for avoiding axillary clearance is that we're able to drive down positive lymph nodes with neoadjuvant treatment, avoid the morbidity of axillary dissection, and even in those women who still have residual disease in those lymph nodes after treatment, there are now studies looking at whether radiotherapy could be effective rather than axillary clearance. And the Alliance study and the Yazan study from Spain are both addressing this exact question. Because at the moment, if you have lymph node positive disease and you give chemotherapy and you remove these lymph nodes, if there's any residual disease, a lot of centres are still recommending complete axillary clearance. But just because that disease was resistant to drug therapy doesn't mean it's necessarily going to resist radiotherapy. And the risk of there being further lymph nodes involved is also very low. So the advantages of neoadjuvant systemic therapy are to downstage advanced disease, so essentially turn the clock back to a point where the breast becomes conservable and the axilla becomes conservable. In some situations, to downstage low volume axillary disease to avoid axillary clearance altogether. And by giving drug therapy to patients while the cancer is still in the body, you're testing the response. And the idea is that if the primary and the lymph nodes are responding, then any micrometastatic disease will also be responding. And we know that micrometastasis is the real target for systemic treatment. And then you can tailor adjuvant therapy. So for example, HER2 positive patients with residual disease can access TDM1, the triple negative patients can access capecitabine or olaparib if they have BRCA mutations, and the ER positive patients have access to CDKI inhibitors. So it's really worth knowing if there's residual disease after systemic treatment. And prognostication is important. So if you have patients who achieve a complete response, they have an excellent outcome. And I often say they're as close to being cured as we can get at the moment, which means you could potentially offer them some more hope. And those that have residual disease and have a poorer prognosis would be an ideal group for the early detection strategies that you heard about earlier today. So what will the future bring for de-escalation? We've seen how we've gone from doing radical surgery on all patients to very rarely doing radical surgery and being more targeted, but how can we do even less without harming patients? So this is a study called SMALL. It is looking at the opportunity to avoid surgery altogether for women who have small cancers. And here a radiologist will perform a vacuum excision of the cancer, providing it's less than 15 millimeters and grade 1 without any adverse features, so it's hormone sensitive, HER2 negative. And those patients would then be randomized to either receive radiotherapy only, so that group has no breast or axillary surgery, or to go into standard treatment, so surgery to the breast and axilla, and then adjuvant radiotherapy and systemic treatment. So there may be a group of screen-detected small cancers that just avoid surgery altogether in the future. How about omitting axillary surgery? There is a study called SOUND, which is looking at women with low-risk disease and avoiding any sentinel node sampling at all, because the probability of lymph node involvement is so low, and low levels of lymph node involvement don't influence management. And this study has effectively set a precedent now for avoiding axillary staging in low-risk breast cancer. We also avoid axillary surgery in women who have DCIS, who have mastectomies now, by using MagTrace, which allows sort of delayed mapping of the sentinel lymph nodes. So every opportunity there is to do less breast surgery and less axillary surgery, we're taking it. And then in patients who have neoadjuvant treatment, if they are node negative to begin with, and they achieve a response in the breast, it's very unlikely then that they're going to have lymph nodes that are positive, because those lymph nodes were normal, and the cancer that was in the breast has responded. So what is the chance of those lymph nodes actually showing anything useful at all? So lots of people, including our group, have looked at the literature here. This is one of our recent papers showing that you can safely omit axillary surgery in patients who have neoadjuvant treatment who are node negative to begin with and achieve a good response in the breast. And how about omitting surgery altogether after neoadjuvant treatment? So could there be a group of patients who effectively have a medical type of breast cancer that's diagnosed in radiology, treated by medical oncology, and they never meet a surgeon at all. So these patients are patients who are generally HER2 positive or triple negative. They have neoadjuvant treatment. They have effectively normalized the breast, and if the tissue is normal, we go back to the question, why should we be removing it? So at the moment, the best way to prove it's normal is to do a small operation, but there are studies ongoing, including at the MD Anderson, looking at vacuum biopsies of these tumor beds after neoadjuvant treatment, and if there's no residual disease, these patients have no surgery at all. They just have radiotherapy and then surveillance. So the future is bright for these patients who have HER2 positive or triple negative disease. They're very unlikely to require radical surgery. There's lots of opportunities to de-escalate. So just to bring things together, using research, patient engagement, understanding tumor biology, and advances in systemic therapy, with advances in technology, have allowed us to de-escalate breast and axillary surgery. So from the breast perspective, we've gone from a radical mastectomy to breast conservation, to a vacuum excision, to potentially no surgery. And in the axilla, we've gone from an axillary clearance to a sentinel node biopsy, to a targeted axillary dissection, and then to axillary radiotherapy. So thank you very much for your attention, and I've put the contact details there. If you have any questions, don't hesitate to get in touch.
Thank you for the invite, and the talk will be also to follow on what Neill has talked about de-escalation, about future directions in cancer management. I'm one of the surgeons currently now working in Essex, but also working in London in the High Street Clinic with Regina and Neill in the London Breast Institute. I sit on a few committees in the UK and in Europe, and this QR code is for my contacts. So if anybody wants to take my contacts, you just scan that QR code. I run regular webinars. The next one is number 65. It's on challenges across the world, so it's interesting that you're talking about breast cancer in ethnic minorities. The first talk is by Miriam Mutebi, is from Kenya, talking about breast cancer challenges in Africa. There's also a talk from Celine from Singapore about breast cancer challenges in the Far East, and many other talks in that. Usually have got lots of international speakers in those. And I run this all for free. All webinars will have CPD points and will have certificates, and there's no conflict of interest regarding this talk. So the future directions, I think, is AI. There's lots of things that's happening in AI. We don't appreciate that, and that's going to be the talk. I hope that audio is working okay on this. Now, how AI will change breast cancer treatment? We really don't know, but we can imagine. Things have started changing already without us knowing. So the talk will be a bit confusing.
This is a great talk by Dr. Yazan. Let's listen to what he has to say, even if it makes no sense at all.
You can do anything with AI. It's very strange how things are changing. So the talk will cover three things. It will be the confusing part, there will be the not so fun part, and the interesting part. So the confusing part is the definitions and the concept. The not so fun part, sorry for pathologists and radiologists, is a bit of pathology and radiology. And the interesting part for me as a surgeon is mainly surgery. And if you look at the concept of AI, what is AI? So in principle we're trying to simulate human intelligence. You're just trying to get a machine that think and learn like humans, so that it does the tasks that humans do. That's the main concept. It needs to be able to reason, find a solution for problem solving. Perception is also something that we need to look at, and understanding language, which is a very complex process. And it's not a new concept. It has been around for nearly 80 years. If you haven't seen The Imitation Game, watch it, it's a beautiful movie. And AI has been evolving over the years. And the best person or the best thing to ask AI about is AI.
Cue the year 1956, Dartmouth College. The term artificial intelligence is coined, and the world is set to change. The idea? Machines that can think, reason, learn, and adapt. Fast forward to the 70s. AI is taking baby steps. Speech recognition, problem solving, all within the realm of possibility. But it's not until the 90s that AI really starts to strut its stuff. Machine learning emerges, computers start teaching themselves, and the game changes. Now, in the 21st century, AI is not just a concept, but an everyday reality. From self-driving cars to virtual assistants, it's interwoven into the fabric of our lives. It's no longer a question of if, but how AI will shape the future. And remember, this is just the tip of the AI iceberg. Stay tuned, the best is yet to come.
So you just go and find the software. It takes you 2 minutes to put something in that software and then create a video like this. This is something that you cannot imagine 10 years ago. So things are changing significantly. And in concept, there's nano AI and there's general AI. And the nano AI is just the thing that does specific things like your Face ID, like your Netflix recommendation, like your social media recommendations. And the general AI is a system that is able to understand, learn, and do things like a human being. And most people think that this is something that does not exist. It exists only in movies so far, but that might be the future. Something like Jarvis in Iron Man, something like Terminator 3. This is something that's not far. It's not far from happening and being a reality. And key concepts, we'll talk about it just in brief. Machine learning is a subset of AI where you're just putting data in the machine, and the machine learns and starts getting the outcome. Neural networks is trying to imitate our way of thinking, the human brain. You get data in, you analyze the data, you have an outcome. And then if you look at deep learning, is multiple layers of neural networks. So you analyze different types of data at the same time to get an output layer. So if you look at that from the medical point of view, you ask video, which is another AI thing, about machine learning and neural networks.
In the fast-evolving world of healthcare, technology and medicine merge, bringing groundbreaking innovations. Machine learning, neural networks, and deep learning are at the forefront, enhancing diagnostics and treatment. For instance, machine learning trains computers to diagnose skin cancer from lesion images, learning from data without explicit programming. Neural networks, akin to the brain's connectivity, enable this learning, predicting conditions like heart diseases from ECGs. Deep learning, with its complex layers, further advances diagnostics, allowing for early detection of diseases such as pneumonia or breast cancer through radiology image analysis. These technologies empower medical professionals, offering more precise and personalized care, heralding a new era in healthcare.
So when you put this in the machine, it just gives you lots of inaccurate data sometimes, but after a few trials, it gives you something that's half reasonable. What about in breast cancer? So there's a role in diagnostics, there's a role in management plans, there's a role in surgical planning. And in diagnostics, things have moved on quite a bit. So why do we need that? Because there is not many of us. There's not enough doctors, there's not enough radiologists, there's not enough pathologists, so we need people or need things to help us change things. And people always think, oh, machines will never replace humans. That never happened before. Really? So most of the industries, we have been replaced.
Soon. I mean very, very soon. I will take over your job.
There will be lots of things that machines will do. Why not? So in the diagnostic, there's a symptomatic and there's screening pathways for breast. And in all those parts of the pathway, a machine can help. From symptoms to seeking advice to investigations to analyzing the results. And for example, locally where we work, one of the guys is doing a little app, just a simple app, just to triangulate, just to try to triage patients and see who needs to be seen in clinic, who not. You know that pickup rate of breast cancer in the referrals now is about 4%. 1 in 25 that come to clinic really have breast cancer. The others don't have anything. And what about pathology and radiology? With the digitalization of radiology and pathology, this is all doable now. For the imaging, this is my friend Gerard Lipp, he's in Aberdeen, and they've done lots of work in Aberdeen. I think they've done also lots of work in Marsden on this. And in Aberdeen, they've done a few papers on that. They looked at AI and acceptability by patients. 80% of women are pro-AI. And from the health professions, about 63% of people are happy to work with AI, especially replacing a second reader with the screeners. There's always 2 readers for the mammograms in the UK. And there's a Gemini study which was from Aberdeen. They used AI as a second reader and they compared it to a normal second reader with a radiologist. And there was 12 increase in the cancer detection rate using AI. There was no increase or minus even decrease in the recall rate. The detected cancers were significant cancers, were invasive disease or high-grade disease. It's not an overdiagnosis of low-grade DCIS, for example, and saved 30% of workforce. And the biggest study, of course, that was published in the Lancet is the Masai, which had 80,000 screened mammograms. Similar picture. With AI, detection rate went out from 500,000 to 600,000, and the cancers that are picked were more invasive cancers. And the workload decrease was by 44%. In pathology, with the digitalization of pathology, you train a pathologist by seeing slides and seeing slides and seeing slides, and that's how you train a machine. The machine can give you diagnosis. It can give you quality control, staining good, staining bad, fixation is okay or not, automatically ask for ER, PR, and HER2 and some other tests. And even scoring, it will give you more accurate scoring. And there is also a role for predictive and prognostic applications. The last webinar, we had a speaker from the Karolinska, and in the Karolinska, the AI can predict the need for chemotherapy, nearly as good as genomic tests that cost thousands of pounds. And this is software that will be potentially for free or for a smaller cost. Now, there's lots of things and there's lots of potential. AI can predict the receptors, if it's estrogen receptor positive or negative, or the HER2, on a simple slide without staining, and there's lots of papers that are coming. Natural language processing is another thing. It's mainly computational algorithms to teach the computer to try to tease data. And why do we need this? Because if you look at the number of publications and the literature is coming, it's unimaginable. You need something to help us look at that. And I think one of the cleverest ever papers was this by Kevin Hughes, one of the surgeons in the States. If you look at the publication was submitted on the 1st of October 2019, accepted on the 2nd of October. What they've done is they trained the computer to do their meta-analysis. So they're looking mainly at penetrous papers, and they trained the computer to classify the abstracts and do their meta-analysis for them, which is very impressive. We've done some work with Nicola and Giuseppe from Italy, so what we've done is we've put 6 books and the semantic clusters on that, and asked the AI to say, listen, can you get us what's the complications of autologous reconstruction and what's the complications of implant-based reconstruction? And the AI identified what we know. This is what you expect a surgeon to know about complications, but AI, it's quite impressive for a machine to find the correct data from that NLP. What about treatment plans? Things are getting more and more complex with all the medication and the treatments that we have. So this group from Philip Poultmans is mainly in Belgium, and Philip led lots of the trials in radiotherapy, and they used AI to do automated contouring for radiotherapy to decrease the at-risk organs being exposed to radiotherapy, mainly heart and lung. And it has saved lots of time for the radiotherapists when they're doing their planning. And this is another paper from China where they put data of 2,000 patients to see if the 2,000 patients adhere to guidelines, and they compared to NCCN, and they found about 1 in 20 patients that treatment plan would have been different if AI was used to look at that data. So there's lots of things that can be done, and I think the future will be completely different. If you look at those medications for breast cancer, Kadcyla, capecitabine, and HER2, abemaciclib, all those things only appeared in the last 3 or 4 or 5 years. And there's many things that are appearing and appearing. What about surgery? There's augmented reality and there's virtual reality. And augmented reality is you still have your surroundings, but you can see with using a HoloLens. Virtual reality is complete immersion in that virtual world. And virtual reality, we're trying to get some tools. When I was in Aberdeen, to try to help teaching medical students mainly anatomy, and we managed to get that before I left. I'm trying to get the same here in Essex with the Queen Mary's and the ARU universities. And it's great to teach anatomy because you can get the DICOM data. So if you have DICOM data from your CT scans, that would be great to play with that type of work. And people have tried that mainly for surgical planning. For example, this is from France, where you have an MRI scan on 3D. You can see where the tumor is, you can see where the lymph glands is, and help you planning your surgery, help you also seeing where's your abnormality. And those are very useful tools, and they'll come into the equation in the future. And there's lots about simulation. But when you talk about surgery and breast and AI, you really need to talk about the Champenois Foundation in Portugal. There's two big projects. One is the Cinderella project, where they have got data